Okay, morning. I'm Dr. Kawatra. So today we are going to talk about the tuning fork test. It's a very important, useful test, and we have our subject. Your name, please. Suraj, who is going to cooperate with us, and I'm going to demonstrate to you the tuning fork test. Now, before we start with the procedure, let us be very clear that tuning fork test has to be described in certain steps. Okay, and as far as the history of tuning fork is concerned, it was first it is attributed to a British musician called John Shaw in 1711. He was the one who discovered tuning fork tests, and the purpose of doing tuning fork test is what? Can answer? To know the type of hearing loss and the idea about the severity of hearing loss. Type of hearing loss is whether it is conductive or whether it is sensorineural, and the extent of hearing loss or the severity of hearing loss, that can only be told by using a set of three tuning forks, which I have kept in front of you. And the commonly used tuning forks are of 256 Hertz, 512 and 1024. Okay, if you have to decide the severity of the hearing loss. Okay, and let me first describe you the parts of the tuning fork. Now, the tuning fork has got the two prongs. Okay, then this is the foot plate, and this is the stem, and this is the shoulder. Okay, the two prongs, the stem, and the foot plate. So this part is going to be placed at the time of checking the bone conduction. It has to be placed over the mastoid bone, and you hold the tuning fork from the stem, and the acoustic movement or the vibration of the tuning fork is in this direction, in the direction of the prong. So the idea is that you have to place the tuning fork approximately 2 centimeters in front of the external auditory canal. The patient is seated in front of you. You place it for checking the air conduction. It has to be approximately 2 centimeters in front of the external auditory canal, and you see the direction. It has to be parallel. You can come and see from this side. Yeah, it has to be parallel, because this is how the sound vibrates. Don't keep it like this. Okay, so you people can come at the back and have a look if you wish. You stand here. This side you will not be able to appreciate much. Okay, so correct direction of holding the tuning fork is like this. Then about the vibration of the tuning fork, you have to vibrate it over a resilient surface slightly above the olecranon process, and you first bring it to your own ear, check the vibrations, and then you take it to the examiner. The examiner takes it to the patient. Are we clear? So this is just the basic idea how you are supposed to be performing the steps. What all are the, now we go stepwise. Number two, we have to know the principles of the tuning fork test. So what is the principles of the tuning fork test? The principles of the tuning fork test are that AC is twice better than DC. Air conduction is twice better than bone conduction, and bone conduction is a function of the cochlea. So every time you are checking the bone conduction, you are checking the status of the cochlea. Okay, so this was about the principle. Now the common tuning fork tests that we perform are Rhinnes test, the Weber's test, the absolute bone conduction, and sometimes Schwabach's. Though Schwabach's is now not commonly performed, because tuning fork tests, the Schwabach's, this ABC, gives better, more confirmative results. So ideally, Rhinnes, Weber's, and absolute bone conduction. These are the three tests you commonly performed, and this is what is commonly asked in the exam. It's a very commonly asked short note in your theory, and it's a very commonly asked in the Viva. How you will may be asked to perform a particular test. If you are given a long case, the examiner might ask you to show how to do a Weber's test, how to do a Rhinnes test, or how do you perform the absolute bone conduction test. So every part of the test is important, and every time you are trying to give an answer, you must explain it in a stepwise manner. So the principle of the test is this, then the talk about the procedure, then you talk about the result, and then you talk about the interpretation. So principle, procedure, result, and interpretation. So these are the four things. Then another important question which is commonly asked is that since you use three tuning forks to assess the severity, so how do you assess that? Because I like to finish that off, because after that we don't use these tuning fork regularly. So if the patient is like, you generally check it for Rhinnes test. If the patient is negative for 256 Hertz, but Rhinnes is positive for 512 and 1024, then we label that the patient has got a mild conductive hearing loss. If the patient comes to be negative for 256 and 512, Rhinnes negative but positive for 1024, then it is considered to be moderate hearing loss. So that moderate hearing loss is generally below 40 decibels. Then if the patient comes to be negative for all the three tuning forks, Rhinnes negative for 256, 512 and 1024, then it is considered that the patient has got moderately severe or severe hearing loss, which is above 45 dB. Okay, so that is the only role where you use the three tuning forks. So examiner can ask you a question, which tuning fork out of the three which you commonly use? Now the answer to this question is that the most commonly used tuning fork is of 512. Okay, not 1024, not 256. So this is the tuning fork 512 which you commonly use. Next question is, why do you commonly use 512? Because this is the tuning fork which lies in the mid speech frequencies. It produces minimum overtones. Okay, so this is the reason why this is the preferred tuning fork, and this is the tuning fork which you use always for Weber's. So you always compare your Rhinnes with Weber's in the light of that. Then only you come to know whether it is a false negative test or is it what. So Rhinnes has to be compared with Weber's, all right, and absolute bone conduction. So the steps of performance is, you first do a Rhinnes test, then you do a Weber's test, then you do an absolute bone conduction, right? So we start with the technique of doing Rhinnes test. So you first explain the procedure to your patient who's sitting in front of you in his vernacular language. So Suraj is comfortable in English, but most of the patients talk in Hindi, so we'll tell him in Hindi, assuming that he is a patient. तो ये इससे जो है आपके कान की सुनने की जांच करेंगे, ठीक है? तो इसमें हम आपके कान के पास ये आवाज़ जब लेकर आएंगे तो आपको बताना है कि ये आपको मालूम दे रही है या नहीं दे रही है। ये मालूम दे रही है या नहीं दे रही, पता लग रही है आवाज़, बहुत हल्की जा। This is how we check the patient. We need to actually not sit and stand in front of the patient. And Rhinnes test, the procedure is that you vibrate the tuning fork, bring it first to your ear, and then you bring it next to the patient and ask, ये आवाज़ आ रही है? जोर से बोलो। अच्छा, तो आपको ये बताना है जब तक ये आवाज़ कितनी देर तक आती है, जब सुनना बंद हो जाए तो बता दीजिएगा। Now this is the duration technique. There are two ways of doing Rhinnes test. One is the duration technique, the other is the intensity method. So we'll first demonstrate by the duration method. तो ये जब ये आवाज आ रही है, ये जब आनी बंद हो जाए तो बताइएगा। अभी आ रही है? नहीं, ठीक है। So what interpretation is that AC is better than BC. Okay, so this is Rhinnes positive. The result is this, and the interpretation is either it is a normal ear or it is sensory hearing loss. Okay, that differentiation we'll come to know when we compare it with Weber's. Okay, let me show it to you, the intensity method. Intense simple, where we are vibrating the tuning fork. ये बताइएगा ऊंची कौन सी लग रही है, ये ऊंची लग रही है आवाज या पीछे वाली ऊंची लग रही है? आगे वाली ऊंची लग रही है. Again, AC is better than BC. Now you must see where I am placing the tuning fork. एक बार चश्मा हटा लो. So you have to place the foot of the tuning fork like this at the level of the mastoid prominence. Okay, the mastoid prominence is the area which is almost at the level of the external auditory meatus. So you will not place it over the mastoid tip, or you will not place it in the hair bearing area. It is almost directly behind the area of the external auditory canal. So that is the smooth area of the mastoid prominence area, that is what it is called. Okay, this is where you place your tuning fork. Okay, so that you have to be very clear where, how you are doing your test, because that is what your examiner is noting. If you are wrongly placing the tuning fork, if you are doing like this, teda meda, so that he'll come to know that you've not done it before. So you should ideally place it exactly 2 centimeters in the direction of the acoustic movement, parallel to the external auditory canal, not high, not low, at the level of the external auditory canal. Okay, and similarly at the back, you can turn your pinna in the front and then place it like this. Okay, so intensity method, you ask for the loudness. ऊंचा कौन सा सुन रहा है? ये ज्यादा ऊंचा सुन रहा है या पीछे वाला? पहले वाला. एक आगे दो पीछे, इसी तरह से कर सकते हैं आप. कितनी देर तक सुन रहा है, उसमें कई बार पेशेंट कंफ्यूज हो जाता है. सो इट इज मोर इम्पॉर्टेंट टू डू इट बाय द इंटेंसिटी मेथड, दैट यू कैन रिपीट. उसमें भी आप एक बार आगे से करिए, एक बार पीछे से करिए. ये ऊंचा है या ये ऊंचा है? आगे वाला ऊंचा है. ठीक है, लेट अस बी वेरी क्लियर. ओके, एंड सिमिलरली यू रिपीट द टेस्ट ऑन द other side. Okay, so you can have situations where aage wala is uncha, then the piche wala, means AC is better than BC. So that is a normal ear or an ear which has got sensory hearing loss. If the condition reverses, patient is not able to hear in the front, or maybe this sound appears to stop early and you place it on the back and the patient is still hearing it, means that BC is better than AC. So the interpretation is it's a conductive hearing loss. Why do we get a conductive hearing loss, or what is the reasoning behind it? Is that when we check the air conduction, the ambient noise is also going there. All right, so the air stops hearing it, and when you place it over the bone conduction, that is only the function of the cochlea. But in cases of conductive hearing loss, when you place the vibrating tuning fork over the mastoid prominence, that time because of the perforation, the ambient noise is cut off. So the hearing at the bone part appears to be better because the ambient noise is cut off. So that is the reason the patient feels to hear the sound in the when you place the tuning fork over the mastoid prominence. That's how BC becomes better than AC. So BC better than AC is conductive hearing loss. Okay? And in conditions where when I talk about Weber's, then we'll talk about the false tests. Okay? So how do we check for Weber's? Weber's is you check the bone conduction of compare the bone conduction. Okay, you see the bone, you place the tuning fork over the forehead, just at the level of the glabella. Okay, बताइएगा इसमें सुन रहा है या नहीं, आवाज आ रही है, वाइब्रेशन कुछ पता लग रही है, एक कान में लग रही है या दोनों कान में लग रही है? दोनों कानों में लग रही है, ठीक है. So it means that it is coming in both the ears, it is equally heard. Okay, or you can also place it over the nasal bridge, or sometimes people place it over the teeth or the chin area, but the most sensitive area is the nasal bridge or this glabella. Okay, so there is no other method. आवाज आ रहा है, दोनों कान में आ रहा है. Okay, so Weber's will either be centralized or lateralized. There are only two things to it. It is centralized, means both the BCs are equal. So that means the patient is having a normal hearing. But if the Weber's is lateralized, supposing to the left ear, so Weber's gets lateralized to the worse ear in conductive hearing loss, and it gets lateralized to the better ear in sensory neural hearing loss. Understand? Are we clear? So there are two results. It is lateralized to the worse ear in conductive hearing loss, or it is lateralized to the better ear in sensory neural hearing loss. So supposing the patient has got a perforation in the left ear. So what you are doing, you are checking the BC. Again, the ambient noise is cut off. So this cochlea will perceive the sound in a better way. All right. So it will get lateralized to the worse ear. Understood? And supposing the patient has got a sensory neural hearing loss of the left ear, unilateral sensory neural hearing loss, then the Weber's will be lateralized to the right ear because this BC is not working. So that is how you equate. All right. Sensory neural hearing loss means cochlea function. So if this cochlea is functioning better, the sound will go there. Now here comes the comparison between a false Rhinnes negative. Now you did a check in unilateral sensory neural hearing loss, you got a false Rhinnes negative. Understand? What does that mean? That, and you check it, you compare it with Weber's. Now this patient has got, if the patient has got a left-sided sensory neural hearing loss, okay, and you did a Rhinnes test, it came out to be negative on that side, right? Okay, but when you did a Weber's, it got lateralized to the opposite ear. So when you did a Rhinnes, your diagnosis was conductive hearing loss, but it was not that way. It was a sensory neural hearing loss, gross. So that's why it got falsely localized. So that is why it is called false Rhinnes negative. Understand? So that is how you interpret your results in comparison to Rhinnes and Weber's. Then we go on to the absolute bone conduction. Absolute bone conduction, aside from the principle that AC is better than BC and BC is the function of the cochlea, there's a third point added to it, that you compare the bone conduction of the patient with that of the examiner, assuming the examiner's bone conduction to be normal. or the cochlear function to be normal. So what you do is you take the vibrating tuning fork and you first bring it to your own ear. Okay, and you compare it. When you stop hearing it as an examiner, you take it to your patient and you obliterate the tragus, external auditory canal with tragus, and place it here and ask the patient. Start. Let me repeat. We first vibrate the tuning fork, bring it over the examiner's mastoid prominence area. When the examiner stops hearing it, you obliterate the tragus, external auditory meatus with the tragus, and bring that vibrating tuning fork to the patient and ask whether he is hearing or not. So if he stops, if he says I don't hear, means that the BC of the examiner is equal to that of the patient. Understand? So that means the ABC is normal. Okay? But if you have only two results to it, one is ABC equal or ABC shortened. Okay? That, what do you mean shortened? When you vibrate it, place it over the patient's mastoid and the patient says I am not able to hear it now, and you bring it over your ear and you find that you can hear it, means that the ABC is shortened. So shortened word is in comparison to that of the patient, because you have already assumed that the doctor or the examiner's bone function is normal. It is never lengthened, because lengthened would mean that the patient is, the examiner is abnormal. So that cannot be possible, right? So ABC, remember, is never lengthened. There are three S's to it, just to remember, which we use for Schwabach's. But still you can remember it is shortened in sensory neural. Shortened, S for shortened, S is for sensory neural. So absolute bone conduction is shortened for sensory neural hearing loss, right? And Schwabach's test is also done in the similar manner as absolute bone conduction. Only difference is that the external auditory meatus is not obliterated, not closed. You don't give pressure. You just obliterate it gently with the tragus, with your finger. You don't give pressure. You don't want to do a fistula test. Okay, and the interpretation again, SSS, Schwabach's, shortened in sensory neural. Okay, but the add-on to it is that it gets lengthened in case of conductive hearing loss, because once there is a perforation, the patient will hear the sound over the mastoid for a longer period of time. And when you bring it over your ear, you will not hear it, because his ambient noise was cut off, so he heard for a longer period of time. Right? It is the same principle as you are applying in case of Rhinnes test. Okay? So that is, but nowadays Schwabach is not done to that extent, but Schwabach's, one line to remember is Schwabach's is shortened in sensory neural hearing loss, and so is absolute bone conduction is shortened in sensory neural hearing loss. So these are the three methods that you do in tuning fork test, and the fourth one is Schwabach's test. Okay, so we conclude here, and it is important, before I conclude, is that it is important that every time when you are performing the test in front of the examiner, it can be a short case. The patient is seated, the examiner might ask you, do the tuning fork tests, or you do Rhinnes test on it. That's how it goes. So you must be confident enough to explain the procedure to the patient, number one. Number two, you should, after explaining to the patient, you should be sure that the correct steps are being followed in doing the procedure. And before you start with the procedure, must tell your examiner, you tell your examiner, see, the principle of this test is this, and I am going to perform Rhinnes test by intensity method or Rhinnes test by duration method, because they are both ways. So if you want to do it in a short way, you tell I am going to perform it by the intensity method. If you want to do it the duration way, which is a little difficult, because if the patient is not compliable, he is not concentrating on that sound, you might create a fallacious result. So intensity method is short, fast, and can be repeatable very easily. You can keep, once you place it in front, once you place it at the back, then you place it at the back, and you place it in the front. So always better to do it by the intensity method and tell to the examiner, I am using the intensity method. If he wants to ask the viva what other method, you can always tell. Okay, and then once you performed it, then you tell, sir, in this case, Rhinnes is positive or Rhinnes is negative. Why? Because BC is being longer than AC, then it is negative. And then you tell that the interpretation of this is that he's got a conductive hearing loss in that particular ear. Okay. And my findings also corroborate. When I had a look, he had a perforation in this ear. So it fits in everywhere. So you must explain it in a stepwise manner. Don't try to skip and jump. Okay. Always go with the principle, the procedure, the result, and the interpretation. So this PPRI. Okay. So we conclude with it. Thank you, dear, and thank you.